The next type of keratoplasty is superficial lamellar keratoplasty. This involves partial thickness excision of the corneal epithelium and stroma, so that the endothelium and part of the deep stroma are left behind as a bed for appropriately partial thickness donor cornea. The area grafted depends on the extent of the disease process to be addressed. The indications are opacifications of the superficial 1/3 of the corneal stroma which not caused by potentially recurrent disease like Reese-Buckler dystrophy, granular dystrophy, and lattice corneal dystrophies. Marginal corneal thinning or infiltration as in recurrent pterygium, Tyrian marginal degeneration, limbal dermite, or other tumors. Localized thinning or desmetocele formation. The next type is deep interior lamellar keratoplasty. It is a technique in which corneal tissue is removed almost to the level of descending membrane. A theoretical advantage is the decreased risk of rejection because the endothelium is a major target for rejection and endothelium is not transplanted in this type of keratoplasty. The major technical difficulty lies in judging the depth of the corneal dissection as close as possible to descending membrane without perforation, and if this is not achieved, the visual outcome may be compromised. The indications are disease involving the anterior 95% of the corneal thickness with normal endothelium and the absence of breaks or scars and descending membrane, for example in keratoconus, without a history of acute eye drops or superficial trauma. Chronic inflammatory disease such as atopic keratoconjunctivitis that carries an increased risk of graft rejection. The advantages of deep anterior lamellar keratoplasty. There is no risk of endothelial rejection, although epithelial, subepithelial, stromal rejection may occur. There is less astigmatism and a structurally strong globe compared with penetrating keratoplasty. And the last advantage is increased availability of graft material since endothelial quality is irrelevant. Disadvantages: it is difficult and time consuming with a high risk of perforation. Interface haze may limit the best final visual acuity. Postoperative management is similar to penetrating keratoplasty except that lower intensity topical steroids are needed and sutures can usually be removed after 6 months. Now the endothelial keratoplasty. It involves the removal of diseased endothelium along with descending membrane through a corneoscleral or corneal incision. Folded donor tissue is introduced through the same small 2.8 to 5 mm incision. Decimet stripping automated endothelial keratoplasty uses an automated microkeratome to prepare donor tissue and is currently the most commonly performed technique. A small amount of posterior stromal thickness is transplanted along with descending membrane and endothelium. In descending membrane endothelial keratoplasty, only the descending membrane and endothelial are transplanted. Because the graft is only 5 to 10 micron thick, it is difficult to handle. However, the grafts are able to attach to the host tissue with less unevenness, which lead to more rapid visual recovery. visual outcomes and low rejection rates are achieved, but intraoperative complication rates are higher than DSAE key. The indications include endothelial disease such as Fuchs endothelial corneal dystrophy. The advantage, the relatively little refractive change in a structurally more intact globe, fast visual rehabilitation, then penetrating keratoplasty, suturing is minimized. The disadvantage, significant learning curve, specialized equipment, and endothelial rejection can still occur.